There is a trap built into Medicare that most retirees walk straight into without ever knowing it was there. It does not announce itself. It does not come with a warning letter. It does not show up clearly on any form you fill out when you first enroll. It shows up later, on a bill, on an explanation of benefits, in a moment where you look at a number and think, that cannot be right. But it is right. And by the time most people figure out what happened, they have already lost thousands of dollars they cannot get back. I am not talking about fraud. I am not talking about a billing error. I am talking about a series of gaps, penalties, and traps built directly into the Medicare system itself that cost the average retiree over $4,000 every single year out of pocket. And the people who design and administer this system are not rushing to explain any of it to you. My name is Margaret, and this channel exists because you deserve honest information. Not fear, not confusion. Just the clear truth about how Medicare actually works, so you can protect yourself and your money. If this is your first time here, hit subscribe right now, because what I am about to share with you is something every person on Medicare or approaching Medicare needs to understand before it costs them. Let's get into it. I want to start with a man named Gerald. Gerald is 68 years old. He retired 3 years ago after 34 years working as an electrician in Charlotte, North Carolina. Gerald is not a careless person. He is the kind of man who reads the instructions, keeps his paperwork organized, and never misses a bill. When he turned 65, he enrolled in Medicare just like he was supposed to. He got his card. He felt covered. He felt like that chapter was handled. What Gerald did not know is that enrolling in Medicare Part A and Part B is only the beginning. What you do after you enroll, which additional coverage you choose, when you make those choices, and what you assume is covered versus what actually is covered, all of that determines whether Medicare costs you a reasonable amount or a devastating amount. Gerald found out the hard way. In his first year of retirement, he had a hospitalization that lasted 4 days. He assumed Medicare would cover it, and Medicare did cover most of it. But Gerald still received a bill for over $1,300 for that single stay. Then his wife needed an outpatient procedure. Another bill. Then there were the prescription costs he had not planned for, and the specialist visits that cost more than he expected. By the end of the year, Gerald had paid over $4,000 out of pocket, despite being enrolled in Medicare the entire time. He had done everything right and still ended up here, because nobody had told him about the traps. Today we are going to go through every single one of them. The first trap is the Medicare Part A deductible and how it works differently than most people expect. When most people hear the word deductible, they think of an annual amount. You pay the deductible once at the beginning of the year, and then insurance covers the rest. That is how most private insurance works. That is not how Medicare Part A works. Medicare Part A covers hospital stays, and its deductible is not annual. It is per benefit period. Here is what that means. A benefit period begins the day you are admitted to the hospital and ends when you have been out of the hospital for 60 consecutive days. If you go back to the hospital before those 60 days are up, you are still in the same benefit period. But if you leave the hospital, stay home for 61 days, and then get admitted again, a new benefit period begins, and a new deductible applies. The Medicare Part A deductible right now is over $1,600 per benefit period. If you are admitted to the hospital twice in the same year with more than 60 days between stays, you pay that deductible twice. If you are admitted 3 times, you could pay it 3 times. That is over $4,800 in deductibles alone from hospitalizations. Most people on Medicare have no idea this is how it works. They think they paid their deductible and they are covered. They are not prepared for the second bill, or the third. This is trap number 1, and it catches people every single year. The second trap is something called the Part B deductible and the 20% coinsurance that never goes away. Medicare Part B covers outpatient services, doctor visits, specialist appointments, lab work, outpatient procedures, medical equipment. The Part B deductible is much smaller than Part A. Right now it is around $240 per year. Once you meet that deductible, Medicare Part B pays 80% of covered services, which sounds good, until you realize that you are responsible for the remaining 20% with no cap. No annual out-of-pocket maximum. None. On most private insurance plans, there is a point in the year where you have paid enough, and the insurance covers 100% after that. Medicare Part B does not work that way. If you have a major surgery that costs $100,000, Medicare pays $80,000 and you owe $20,000. If your cancer treatment costs $200,000, you owe $40,000. There is no ceiling on what you can owe under original Medicare. This is the gap that sends people into financial crisis every year. And it is the gap that most people do not discover until they are already in the middle of a serious health situation with nowhere to turn. Gerald's outpatient bills were exactly this. 20% of every procedure, every specialist, every piece of equipment, adding up month after month with no end in sight. The third trap is the prescription drug coverage gap that still exists inside Medicare Part D. Even after years of reforms, Medicare Part D still has a structure that can cost you significantly more during certain parts of the year. Here is how it works. When you first start using your Part D drug plan in January, you and your plan share the cost of your medications according to the plan's normal structure. But once the total cost of your drugs, what you paid plus what the plan paid, reaches a certain threshold, which right now is around $5,000, something shifts. You enter what the rules call catastrophic coverage. The good news is that once you reach catastrophic coverage, your costs drop significantly. The challenge is getting there. In that middle zone, many people find their costs are higher than they expected. For someone on multiple expensive medications, this zone can represent hundreds or even thousands of dollars in costs they did not budget for. And because the thresholds reset every January 1st, you go through this cycle every single year. People on fixed incomes are particularly vulnerable here, because a bad month of drug costs can throw off an entire budget, and there is almost no warning when you are approaching the threshold. Your pharmacy just charges you more one month and less another, and many people never understand why their prescription costs keep changing. The fourth trap is one that Gerald walked directly into, and it is called the Medicare late enrollment penalty. When you first become eligible for Medicare Part B at 65, you have a window to enroll without penalty. If you miss that window and enroll later, Medicare adds a permanent penalty to your Part B premium. 10% for every 12-month period you were eligible but not enrolled. And the word permanent is the one that matters here. This is not a temporary surcharge. It stays on your premium for as long as you have Medicare. For the rest of your life. The same penalty exists for Part D prescription drug coverage. 1% of the national base beneficiary premium for every month you went without creditable prescription coverage after becoming eligible. Again, permanent. Now here is where it gets complicated. Many people who retire before 65 have private health insurance through their former employer or through the marketplace. When they turn 65, they assume that their existing coverage counts as creditable coverage and protects them from the penalty. Sometimes it does. Sometimes it does not. Whether your existing coverage qualifies depends on specifics that most people do not know to check. And if you get it wrong and enroll late, you carry that penalty forever. Gerald had a gap in his Part D enrollment because he thought his retiree health plan covered prescriptions adequately. It did not meet Medicare's definition of creditable coverage. He now pays a permanent penalty on top of his regular Part D premium every single month. The fifth trap is what happens inside the hospital that most people never see coming. It is called observation status, and it is one of the most confusing and costly situations a Medicare patient can face. Here is the scenario. You go to the emergency room feeling very unwell. The doctors decide you need to stay for monitoring and treatment. You spend 2 nights in the hospital. You receive care. You feel like an admitted patient. But there is a distinction that Medicare makes that most patients never know about until they get the bill. You can be in a hospital bed receiving care and technically be classified not as an inpatient admission, but as an outpatient under observation status. This classification is made by the hospital, not by you, and it is often not communicated clearly to patients or their families. Why does this matter? Because Medicare covers inpatient hospital stays under Part A and outpatient services under Part B with very different cost structures. If you are under observation status, your stay is billed as outpatient. Your costs are calculated differently and can actually be higher in some situations. But the bigger issue is what happens if you need skilled nursing facility care after your hospital stay. Medicare will only cover skilled nursing facility care after a qualifying inpatient hospital stay of at least 3 days. If you were under observation status, even if you were in that hospital for 3 nights, it does not count. You leave the hospital and need rehabilitation care, and Medicare will not cover it, because you were never technically admitted as an inpatient. The out-of-pocket cost for skilled nursing facility care, without Medicare coverage, can be hundreds of dollars per day. This situation happens to thousands of Medicare patients every year. Patients who had no idea there was a distinction between being admitted and being under observation, who had no idea that a classification made by the hospital without their knowledge or consent would determine whether a major expense was covered. Now, I want to stop for a moment and tell you something important. These traps are real and they are costly, but they are not unavoidable. There are ways to protect yourself from every single one of them, and that is what I want to focus on now, because this channel is not about making you afraid. It is about giving you the information you need to make smart decisions. The most powerful protection against the gaps in original Medicare is called a Medicare Supplement Plan, also known as Medigap. These are private insurance plans that are specifically designed to cover what original Medicare does not. Depending on which Medigap plan you choose, it can cover your Part A deductible, your Part B 20% coinsurance, your Part B deductible, and in some plans even your foreign travel emergency care. The most comprehensive Medigap plan, Plan G, covers virtually all of the out-of-pocket costs I described today, except for the Part B deductible, which is only around $240 per year. With Plan G, you know almost exactly what Medicare will cost you every year. No surprise bills. No unlimited 20% coinsurance. No terrifying hospital statement. The trade-off is that you pay a monthly premium for your Medigap plan on top of your Part B premium. Depending on your age, location, and health status, that premium might be anywhere from $100 to $300 per month. For many people, that known monthly cost is far preferable to the unpredictable and potentially devastating out-of-pocket costs of original Medicare alone. The best time to enroll in a Medigap plan is during your Medigap open enrollment period, which begins the month you turn 65 and are enrolled in Part B. During this window, you cannot be denied coverage or charged more because of your health history. After this window closes, insurers in most states can underwrite you based on your health and may deny coverage or charge significantly higher premiums. If you are already past 65 and do not have a Medigap plan, it is still worth contacting your state health insurance assistance program to understand your options. For the prescription drug gap, the primary protection is the Extra Help program I discussed in our last video. If your income qualifies, Extra Help can dramatically reduce or eliminate your Part D costs, including during the coverage gap. Even if you do not qualify for Extra Help, reviewing your Part D plan every year during open enrollment from October 15th to December 7th is essential. Drug plans change their formularies, their premiums, and their cost structures every year. The plan that was best for you last year may not be best for you this year. And yet most people never switch because they assume their plan is fine. Going to the Medicare Plan Finder tool at Medicare Governor every October and entering your specific medications will show you exactly which plan in your area covers your drugs at the lowest cost for the coming year. This one annual review can save hundreds of dollars. For the late enrollment penalty, the protection is knowledge and timing. Know your enrollment windows. Know whether your existing coverage qualifies as creditable coverage before you decide to delay enrolling. If you are still working at 65 and covered by an employer plan with at least 20 employees, you generally can delay Part B without penalty. But if you retire, if you lose your employer coverage, if your employer has fewer than 20 employees, the rules change. Contact Medicare or your state health insurance assistance program before you make any decisions about delaying enrollment. One wrong assumption can cost you permanently. For observation status, the protection is advocacy. If you or a family member is hospitalized, ask directly and specifically whether you are being admitted as an inpatient or placed under observation status. You have the right to know. If you are told you are under observation and you are likely to need skilled nursing facility care afterward, ask whether the status can be changed to inpatient admission. You may not always be able to change it, but you have the right to ask and to understand the implications of the decision before it affects your coverage. Let me come back to Gerald. When Gerald understood what had happened and why, he made changes. He enrolled in a Medigap Plan G during a special enrollment period he qualified for. He reviewed his Part D plan during open enrollment and switched to a plan that covered his specific medications more efficiently. He now knows to ask about inpatient versus observation status if he is ever hospitalized again. Gerald's out-of-pocket Medicare costs dropped by over $2,000 in the following year. Not because his health improved, because he finally had the information he needed to make the right decisions. The same information you now have. Before you close this video, I want you to do one thing. Go to Medicare, Governor, and create a Medicare account if you do not already have one. Once you are logged in, you can see your current plan, review your coverage, and use the Plan Finder tool to compare your options. Then call your state health insurance assistance program at any time. The number is available at shiphelp.org. These are free counselors available in every state who can review your specific situation and help you understand every option available to you. They do not sell insurance. They have no financial interest in what you choose. They are just there to help you understand. Use them. If this video helped you understand something about Medicare that you did not know before, please subscribe to this channel right now and share this video with someone you care about who is on Medicare or approaching it. Drop a comment below and tell me, did you know about the observation status trap before today? I want to know. I read every single comment. I am Margaret. I will see you next week.